Oh yeah.
Yeah, so what brought you to Maine? I mean, I think you have a professional history and that's intersected with some illness but now you're here in Maine. So tell us a little bit about that and what you're hoping to do well now that you've arrived in this great state. So,
Yeah. So historically, from a professional standpoint, I'm a neurorehabilitation psychologist. And back in the day, I was on faculty at the University of Utah in their division of physical medicine and rehabilitation. And myself and a few others, we had interest in neuroimmune axis disorders and related conditions. And so we developed an Ehlers-Danlos specialty consult clinic, and I've done a fair amount of research in that area, amongst other parts that fall within that neuro rehab realm. And was chugging along professionally in that manner. And COVID came, and I picked up COVID early. It was in 2020. And after that, I developed, what some folks call long COVID or PASC, or, this post-COVID, syndrome of conditions. And it made, it changed my direction. It was one of those things that was it interesting in a lot of ways, quite awful in a lot of ways too, and life changing. But to work within that neuroimmune area beforehand and work with a lot of folks with ME/CFS, mast cell conditions, and a whole host of these, poorly understood or overlooked conditions. To have a bit of an understanding about that, and then to be, have that personal sideswipe with it was a profound experience and continues to be. But anywho, from there I kind of detoured. We had to kind of change paths. I went on disability for a little while because my health status was so poor, and tried to figure out professionally what I should be doing. And so I tried on different hats and have eventually built back up to a good degree. And there was a new job that was exciting here in Maine, in Portland, with MaineHealth, and it's back in rehab, not specifically in that neuroimmune axis disorder kind of realm of conditions, but still in neuro rehab and specifically on their acute floor. Um, so I just arrived. I'm only about three. This is my third week into the job. So I'm super happy to be here, but had some detours, along the way, both, yeah, professionally and personally, and the health status and health conditions were pivotal to shifting and pivoting related to that.
and did I remember correctly, Stephen, that so your job is a part-time, it's not a full-time uh,
That's
position as well, right? I mean, that's an adjustment that you've made.
absolutely, and that's a good point. It's one of those things where, with the move specifically and starting a new job, and especially one in this area, I was a bit worried to hop in full time. And just because I don't know how I'd respond. And so I wanted to take a more stepwise approach to getting back into the area that I really enjoy. And so I took a half time, a half
Mhm.
FTE, and we'll see if I build, from there. I sure hope so. But as we know, these conditions wax and wane, and can change. But
Well, I'm sure MaineHealth is lucky to have you both from what you've historically done and then the personal, the irony, of course, of having you sort of land in this mix brings a different perspective, which I want to get into. And I'll just share a little bit of a parallel. I mean, our stories are different in the sense that so I developed ME back in 2009, and didn't really know what it was. And I had a career in veterinary medicine. And I think the lucky part for me was that I was working for myself. So I wasn't working for an institution. I was only accountable to me. I could take days off. I worked in Texas. It was very hot in the summertime. So I had a normal out to be able to limit my activity. because my symptoms started in the sort of late spring of '09. And and luckily, after a sort of an initial dip, I was able to, generate enough capacity to work for over a decade. But then the combination of aging, and because we just don't know what happens with age with this
Right.
condition either, and the heat, I just knew that I was at that sort of tipping point. I worked with horses only,
Hmm.
and great creatures, but they require some physicality, and I just found myself spending all of my downtime trying to recover for the next day. And I just knew that I was at a point where I didn't want to have anything happen to an animal underneath my care. So I retired 4 years ago and moved east. I'm from the east originally. And so my goal was to get to cooler weather. So that was part of my intentionality with regard to my illness. For me, heat is a driver that certainly wipes through my any energy capacity that I have. And so that is, so I'm still sort of, in terms of identity, I think what the hard part is I loved what I was doing. And it's really been a challenge to really shift that identity to now I'm owning. I mean, I didn't necessarily not own my illness, but it was because it was hidden. A lot of my clients didn't know, and I did the work well enough to that they didn't suspect. But now it's a different entity, and that's why I'm part of this advocacy work and having these conversations with you is to sort of bring it front and center, and also share. I think both of us with regard to having a medical background. And I'm grateful Christy's in the audience as well, because she's got a medical background. So you get to see it on both sides. And I think one of the things that I would love to dive into as you look back at your course when you first got COVID and then started to see, started that journey from the patient side of the table, what were some of those what were the good moments and what were those challenging appointments, and and let's sort of dig in a little bit there to sort of see what it was like to be on the other side of the table, sort of, or the equation, so to speak.
Yeah, that's a great question. It's funny. You can intellectually understand things, and then when you experientially are in the mix, it's different, right? So there were many experiences that were quite unsurprising. And there were experiences that still felt like you're getting hit by a freight train, even though you could observe it happening intellectually, like, oh, this is what's happening. And this is what, I've worked with so many people about like, how do we mitigate this from happening? What do we do to prepare for this and that? And so it's a rich and oof, it's a big experience. I think some of the benefits that I had is I had some excellent colleagues. Being in rehab, I had some wonderful folks with physical therapy, occupational therapy, speech therapy, physiatry, and then again, like good immunologists, neurologists, different folks that I could lean on who first believed that these conditions were real, which is that, that thing people always dance around, right? And were open to discussing it in nuanced ways. And so I was very, very fortunate. That was one thing that I recognize as a rarity. I had a number of good friends and colleagues that I could really consult with and make some gains, or at least get in a direction that was helpful. That being said, these were friends and colleagues, and so you can rely on them to a certain extent, and you still need to round out your care in a number of other ways. And that's when you run into those very, very common stories of it being psychiatrized. It's all in your head. These are things related to stress and anxiety, or we don't really know. And so this is all we can do. And that's usually the best case circumstance when it's recognized and in earnest, they say, no, we can't do much here. But that's still a dead end. And so there is that interplay of kind of being able to recognize it almost in a meta way, like observing it from the outside and still being in the mix and experiencing it at the same time, um, which is confusing and complex. I'm sure you've had similar
Right.
experiences.
And do you feel like having you tested positive for COVID when you got it. So do you feel like that helped with some of the um, dismissing that this wasn't real? I mean, I don't, I don't remember the timeline of within, I mean, the whole pandemic with regard to when there was recognition. Certainly within the ME population, they were predicting we were going to have
Oh
individuals
yeah.
long COVID, but the reality that there were individuals who were going to be circling back. Were you caught up in that mix, or were you, I mean, early enough that says, boy, okay, Stephen's had this long enough, and so we now recognize that it's connected to this COVID positive? Or was it far enough apart where you thought they're thinking it's not related?
It's a great question. It was a mixture, right? I kind of had that inner circle of folks that I could rely on, and that added to kind of the quote unquote veracity of the medical condition. And I was also living in a region where there were a lot of COVID deniers, and that had a parallel to,
Hmm.
yeah, post-COVID is not a real thing, even amongst the medical community. And then, of course, you have just the historical roots of providers who, you know, may be very well intended, but have developed biases along the way, be it in an early training or, those things that can occur where when we see this, it means this. And unfortunately, that sometimes translates to this is a mental health condition, or
Right.
this is not biological in nature, or and so unfortunately I felt like even with my leg up of having some dear folks who were in the mix in that kind of specialty area, I still needed to I still needed to branch out, and I ran into a lot of very frustrating experiences
Hmm. Hmm.
that required extra heavy lifting and oftentimes dead ends, or all of those outcomes that.
Right. Yeah. I think that, it's interesting because I think if I look back at my journey where I got sick one afternoon and had sort of classic flu-like symptoms, went to the ER only because my legs were very, very painful and seemed abnormal. There was a disconnect between those symptoms and sort of the general malaise I was thinking. And I mean, obviously I was diagnosing myself, but and then by the next morning I woke up and I knew, my body felt different and it never has shifted back to that. There was definitely a causal relationship. But I think one of the things I look back on in terms of diagnostics and you know, when I even for veterinary patients, four-legged patients, the idea of a virus is that it comes and goes. So you get sick, you have 3 to 5 days, and then it goes away. And so that then going home, so when I was discharged from the ER, it was okay, you've got the flu, you'll have this course and then it'll be done. And my fever was gone in 3 days. So it was very classic. But I think one of the things, if I think back to ways where the diagnostic process might be improved, is to figure out how to be able to dispel the sense that it's just the flu and you just need to go home and you need to be better, because I didn't see another physician for 18 days.
Sure, sure.
And so any diagnostic capacity to measure whatever other viruses
Hmm.
to look into, that window was lost
Right.
because I'm now 18, 19 days. And at that particular point, they looked at things that I would have gotten from animals, like, okay, because of my profession. But a lot of that was gone. He's like, oh, that's when I started being treated. The few treatments that were given to me were, let's treat you for Lyme, let's treat you for some other things. Um, but I think back to that if the window had been tighter, is there it's still a grab bag because you don't know. In your case, there was the COVID pandemic, so having
Right.
COVID be more likely. But I think that's one of the challenges is to dispel this that it's not real just because it's not on paper.
Right. Right.
The diagnostic process, I think, and I wonder because I think I've often wondered within the medical training, is there a better sense that viruses can linger, or is it just 3 to 5 days still? Is it still that sort of short-term piece that I think is a problem for me, at least?
Oh yeah, and I've encountered so many folks that I've worked with on the other side as a clinician who have such similar stories, right? They had, it was the flu. It was this thing that occurred, came and went, and then these new symptoms develop, and kind of like you said, where's the evidence for the etiology? And it gets lost because it was just a flu, right? Maybe it was a bug bite, maybe it was this or that, and yeah, the nosology and the way we diagnose is concerning at times because it's always more complex than these checklists that we're given. And, we have only so much time to be able to account for all of these things. Yes, that's realistic. And I don't know, it's very rarely so neat to have X, Y, and Z equate to here's the diagnosis and we're done, right? Um, yeah, but it's funny. I keep thinking about evidence. I had the flu, and then you have to somehow prove that to folks or somehow lead people back. Could it have been this? If so, what does this mean for future treatment? What do we do? And so on and so forth. But
I think
Yeah, and I think that was something that I certainly struggled and never was able to get anybody. My arc was I never really got anybody to sort of believe. And so I think I ended up making my own diagnosis years later. I mean, but I pursued, I don't know about you, but I mean, I pursued treatment or actively for about 8 years. And then I finally sort of gave up. But I think you touched upon one piece that I want to dive into a little bit because I think but since we're both had care for two-legged individuals and I have four-legged patients and time is something that we don't have just oodles and oodles of. I remember my dad's a retired or was it a physician, and he was back in the day where you could spend 30 minutes with a patient. And I remember when I was graduating from veterinary school, and he said, "Remember that the best pieces are right at the end. You'll get the nuggets right at the end."
love that.
And I think one of the challenges is that I really respect is that clinicians nowadays, and you know more than I do with regard to all of the other pressures. I know time is certainly one that we have to be able to honor, is that if there's only that 10 or 15 minutes in an appointment, and as you just said, if we don't check off the boxes and if there's not an immediate diagnosis that's coming right in front, there's a lot of stress at that moment. How do both within the patient physician conversation to then say, how does that end? How does that appointment end with regard to, is it a referral to, the next person? So we get moved on to the cycle of specialists. Or is there a way to be able to keep that continuity of care, but it's uncomfortable to not have an answer at the end of the appointment?
Yeah.
But 10 minutes, I know some things come to light in 10 minutes, but a lot of things don't, even routine. And I feel like I want to be able to figure out ways to be able to help physicians be able to stay with us, but realize that there's going to be what kind of tracking do we do and come back? Because, for example, I don't know about you, but for me, one of the classic signs for me that I've looked back on that no clinician really caught in on was I immediately became very sensitive to noise. So like overnight, I could not tolerate the commercials on the TV that get louder so you could pay attention. And I had to turn them off. I had to mute them. And so but no one, I don't think any clinician I saw, for fault of my own, that I didn't know to share that. I don't think it ever came up as a sign that something else is going on with this woman because this is started right then. Were there things like that that you feel like part of your story wasn't being heard? And how do we get there? How do we help that piece?
Oh yeah, absolutely. And Christy, I just noticed your comment, and it relates quite well, and you're absolutely right. Like, one of the goofy benefits of the whole COVID pandemic, well, this can go in a lot of different directions, but like, there was a clear trigger, and we can put the spotlight on the inherent sexism in medicine, of overlooking a lot of these conditions that had been more related to women,
Mhm.
for historically, right? Just
Yep.
from numbers alone. And so you have the COVID pandemic, quite frankly, men getting these conditions, developing these conditions in higher numbers. And so there was a spotlight put on it. And so I do think that made it easier in a lot of ways for a lot of people. And folks benefited from that. And unfortunately, that, you know, it's based on a lack of justice for decades and decades, which is under guessing the numbers, quite honestly.
Mhm.
Um, and so, yeah, there's a lot that have been missed and continue to be missed. I think it's still a problem with post-COVID, and it was something that was getting noticed and discussed, which was a privilege for folks that did develop these types of conditions at that time. And am I misspeaking, Christy? I don't want to put words in your mouth on that one.
No, no, that's exactly right. I actually like I've read books about, the history of sexism in the medical field, and as far as like treatments and gynecological conditions and all this stuff being underfunded for research, and a lot of like psychologizing of the illnesses.
Mhm.
And then just I think the lack of awareness about all of that comes from the like sexism that's involved and the lack of funding. So then nobody really knows about it. And
Yep.
even though I trained as a nurse, I just took what the doctor said because I had trust when I was 18 that as
Right.
a nursing student, like they must know what they're talking about.
Right.
But as I progressed and got worse and worse, nobody had the answers. They just like, oh, you're like a medical anomaly. And I'm like, that's fantastic. Like, so I had to do a lot of my own research, and I think that a lot of people have to do the same thing. I'm just fortunate where I have some understanding of the medical field to have even gotten to a point to be diagnosed and have the privilege of being well long enough to have insurance that allows me to go out of state and to choose what providers I want versus
Right.
where I'm at now where I can't drive. And
Hmm.
when I had Medicaid the last like year and a half. Oh my God, my cat is being grumpy.
That's fine. What's your
Yeah.
cat's name?
Louise.
Oh my
Louise.
God, that's great.
Perfect.
And I have a
Louise.
Thelma too.
Okay, well, that
Yeah.
perfect. Perfect.
But I think that people that don't have knowledge of the medical system and don't have the ability to really advocate for themselves, and then the lack of transportation and insurance, like it really, I can't imagine how many people in Maine would be able to get diagnosed.
Right.
I only got diagnosed after COVID came out because I'm like, wait, this sounds like me. Like I've been wondering for years what the like common theme was between all of the comorbidities that I developed. And my course is so strange I think in some ways compared to others because some of the symptoms that are more traditional with ME/CFS didn't progress till later. I
Mhm.
Right.
started having like more like GI and gynecological issues first. Like I
Mhm.
ended up just like throwing up one day and I thought I had the flu and then it never went away and now it's been over 9 years.
Mhm.
So, I think that because of that like non-traditional route, like it made it harder for me to recognize. But once information about long COVID started coming out, I was like, I've never had COVID, but this sounds like me.
Right.
And that
Yeah,
led
and
to
I
new
think
research.
yeah, and I think that's where and thank you for sharing that, Christy. And I think, one of the things in the time that I've spent sort of being patient forward with regard to my identity is, we connect and we have this immediate bond with other individuals because we understand. I mean, and I think that's the challenge is that things don't fit they may not have the top 10 pieces, or they're different 5 or 10 pieces of this complex issue, and then they're not collated and they're not sort of watched or even given some time, because that continuity for me, I guess, is continuity of care to have one person. Um, right now, I have a primary who, she's marvelous, and that was my first question when I met her here in Maine was, does she believe in this condition? Because if she didn't, I'd move on. But and she does. And so, but she knows that I manage things pretty well, but she's able to then, be a buffer for me. And I think a lot of, in our early stages of illness, and as you said, the three of us have more medical knowledge than most people. And so we start to be able to understand what's going on. And we know what a mitochondria is, and at least we've studied it. And I think it's frightening for others who don't. And I think that ability to figure out how to um, have that conversation with patients and physicians to um, lower the expectations that everything's going to be figured out in minute one,
Right.
and being able to then say, can we have another appointment and just stay with the same person? Then one person's looking after you rather than you could have some specialists here and there, but one person is that central knowledge, and it could be shared with the patient because we're living it and we know ourselves better than anybody else. But I think that's part of it, that I find. And I think, just going back to your comment about the sort of sexism and female versus male, and I don't, Stephen, I know you pretty well, but not that well yet. But I know that one of the moments if I look back at my history of physicians with whom I visited, the sports medicine physician was actually the one who saw me fall apart, in both physically. They asked me, my quadriceps are very weak due to the illness, and that was presenting complaint. I was referred to them because my legs were weak and I had been a runner. And he said, "Oh, I think you're, the out of shape" words came out of his mouth. And he said, "Okay, let's just see you jump on one leg and then the other." And on the first leg, I managed to stay upright somehow. And then the second one, I fell down, collapsed, and I burst into tears. And I was desperate at this point. This was later on in the journey. And the tears just completely uh, derailed the whole appointment, because the fact that I fell and was so weak that I fell was lost because I was now a woman crying.
Right.
And unfortunately, that was the case. And I got up and I mean, I have a temper before I got COVID. I mean, before I got ME, but I have it now.
Good.
And I own it. I mean, when my mitochondrial batteries drop, my voice, I snap. And so I did. And I think then I knew that I was in that psychological place. And I think that's the other part of this, is that there's a desperation as we get passed from person to person to person, and we know our bodies, something's changed, is to be able to have those emotions in the room as well. And that's a tricky wicket. And I don't know if either one of you have had that place where it just you get that desperate that you get really upset. And that for me was a moment where Yeah, my inability to exert was lost in all of that, unfortunately.
Yeah. It's funny, and obviously coming from the psychology side of things, and specifically, I've always worked within kind of more medical settings, inpatient, outpatient, rehab, things like that. And the biggest referral or consult we get is patient is crying, right?
Mm,
And so I'm kind of glib and not glib, by saying that,
mm,
but that's not a diagnosis. That's someone having a normative emotion to something difficult. And again, that psychiatrization, the psycholization, psychology, I can't even say that word that you said, Christy, but is right on, where it's so easy to divert, especially at a moment like you described, Carrie, where there were objective findings of weakness, and that would have been excellent to focus on. And a normal emotion comes up, and zoom, we're taking a left turn away from it. And but emotions.
It definitely happened to me too. After a year of throwing up, and I had to stop working for a little while at that point. I did go back, and then I got worse again. But I got down to 109 pounds, and they kept telling me it was just acid reflux and anxiety. And I'm like, there's more at play here. Like, I was a psych nurse. Like, I at least know, like, this is not psychologically driven. Like, something's wrong. I'm upset that I'm like wasting away, and that I was only 2 years, 3 years into my career at that point, and I'm like, I want to know why I'm losing all of this stuff. I was only 25, and I went to get an extra opinion, of course, after a year of, kind of being gaslit, and they wrote in my chart without discussing with me that they thought I had borderline personalities because I dislike multiple providers. And I'm like, good thing I know what that means,
Yeah,
because
right.
if that just kept getting passed through my
mm,
chart,
Right.
no provider would take any of my like symptoms seriously.
mm,
Because knowing that what borderline personality presents as, like, everyone's just going to think that I'm trying to manipulate people or I'm making things up. And I would just, like, I think I've also read before that people with borderline personality disorder are more likely to have their physical complaints, regardless if it's ME/CFS or something else, to be shrugged off, because they're just like, oh, it's behavioral,
Right.
or, oh, it's just borderline personality. It's because they're borderline. So, and
that's it.
everyone has similar experiences of some point being told they're anxious or they're emotional or what have you. I think I was even more upset where I had that knowledge. I was like, but I'm one of you. Like, I want to keep being one of you. Like, why would you think that I'm doing this for
Right,
fun? Like,
right.
Right.
Jess, do you have a question?
Yeah, I'm just listening to all this. And so I don't have a chronic condition, but I feel like viscerally the frustration of like not being heard. You're not taking me seriously. You're not really seeing me. And it's just, I'm just wondering how can you actually communicate and express your genuine emotions, your, symptoms that are invisible, your grief over, this change in your identity. How can you communicate that to a healthcare provider in a way that is going to make them, hear you, take you seriously, not gaslight you? Or it's almost like a catch-22, because if you try to express yourself deeply, it's almost like they'll just write it off as a mental health issue, or and maybe it's not even fair to even put that on the patient. Maybe it's, something that needs to be trained into healthcare providers. But I'm just curious, how can you communicate, with to your provider?
I'll defer to the Stephen and Christy first, and then I'll give my 2 cents. But I mean, based on your background, and I have a cat too. His ears pop in here every once in a while. This is Max, who loves to visit at the computer. But I mean, I think it's really what kind of methods, and I'll talk a little bit about what I've done personally, but or I can start with that. But I just I think it's a great question because Yeah.
Yeah, that's a superb question. And Christy, I don't want to hop in because I'm sure you have excellent thoughts on this too. This is a tricky one.
I kind of was like, I don't want to jump in and take over
No. So
Gary's
Stephen, why don't
conversation.
you go first and then Christy will, yeah, go ahead, Stephen. Yeah.
Absolutely. Oh, I think you need to go in knowing that there's a potential and oftentimes a high potential of failure. So it's going to be hit and miss, right? And that's its own burden on the patient. That's unfair, but it is also realistic. And so again, I'm not condoning that, but realistically, there's a high probability that there's going to be a swing and a miss, and that's an added burden and extra work for the patient. Um, that's a helpful thing for me personally because it's an acceptance of reality, not an approval of an injustice, but it's an acceptance of what potentially could happen, and then I can do the coping and the work around it because that's my responsibility, right? Um, I found what's been most helpful is coming in with a plan, almost a communication plan, and making sure I have a good outline of what I want to talk about and kind of some succinct ways of describing it. And that's helpful for me because I have a relatively, decent set of jargon that will translate in the office, but I'm still a patient. And for those of us with, autonomic messiness, that little uptick can certainly make me less eloquent. And when the emotions do start coming in, that certainly can make me less eloquent and can derail me. Again, not fair for to be dismissed in that situation, but me having kind of an outline of how to get what I need out in the most succinct way possible um, has been most successful. Again, these are all added burdens on the patient. No
Mhm.
approval of it, but we deal with what we have to deal with, which is a gross thing to say, but
Mhm. And do you feel like any of the physicians with whom you visited, maybe they knew Stephen before you had long COVID and now they see the Stephen afterwards? Can they appreciate that there might be a difference in, or, maybe oh, there's the old Stephen and this is the new Stephen? Can they see those two things?
that's a really excellent point because sometimes it's like, the perfect answer, a psychologist always says is like, well, it depends, and sometimes, right? Um, so yes, but the thing that comes to mind is it's so dependent on health status at that moment, which is so variable, right? So if we're in kind of a fatiguing trajectory, I might look real bad at that moment. However, if I've done my prep work of rest and X, Y, and Z, I come off pretty darn good. But they might be missing how I'm doing right after it when I'm pretty whooped by the experience.
I want to come back to that, and I'll ask Christy about her this multiple personalities, because I think the point of your intention, our prep for these appointments and what happens afterwards or beforehand, that the window of time
Yeah,
that the physician is seeing us again is setting the dice with regard to their anyway, they're seeing us when we're well, but we prepared, we participated. We're like, oh my God, I got to get to the office, so I'm going to do all of this stuff and I'm going to look good.
right,
But then we look too good.
right.
So, Christy, we do. I mean, I think that's a problem.
Yeah.
So Christy, in terms of did you find any ways when they started to talk about that you had multiple personalities? Did you find ways to be able to articulate this or be successful that got through the narrative or?
So, multiple personalities and borderline personality disorder is different. So I just want to make
Sure.
sure you
Yeah,
go
yeah,
that.
right.
Um,
I think it's just trying to talk very generally.
yeah.
You have the knowledge behind that. I don't, but I'm just talking about just the same way I'm couching it with regard to the the old Christy versus the new person. They're seeing something different. These two different how it's showing up. So
Yeah. It's funny that you mentioned that, like the old Christy versus the new. Like when I actually at first when I had the fatigue, it was depression. And then I was like, I'm not depressed. I'm just exhausted all the time. Like I love life. I love my activities. I'm just exhausted. Eventually I got listened to and I got the narcolepsy diagnosis.
mhm.
And now it's believed that I was misdiagnosed because it doesn't make sense. Like I was in nursing school when that happened. My sleep schedule was extremely erratic. And if anyone had asked like post-exertional malaise stuff, I think I would have been diagnosed more quickly.
Mhm.
And if I'm at least like if it was brought to my attention, like I would have been more like astute to realize there may have been certain times that I was experiencing it more.
Yep.
Like especially around like certain tests and like projects that were important. But like all of my notes before, they describe me as like hardworking, like nurse, like pleasant. And then like as soon as like I'm getting worse and I feel like I'm not being listened, like I said, a year after, almost a year of puking at that point, and I'm like, something is wrong. Like need to do more looking into why this is happening. And then when I told them I wanted a different opinion, got that in my chart, a lot of my stuff came into uh, um, you know, crying hysterically. It's like, like bawling in the office. Like all of these, like this description of me as a person changed in the eyes of the medical profession because of
Right.
this desperation of I just want to feel better. What is wrong with me?
Right.
And I think that it's a very like systemic problem as healthcare providers. Like I can't like speak for how things are taught in medical school, but in nursing school, you get like a very small amount of like mental health, and then they push so much of the other medical part. And I don't think that we have enough training on how to deal with other people's emotions. And like, we're also rushed by the system. Like, it wants you to spend less time with patients and do more. And it just seems like it's increasing like over the years. I became a nurse in 2014, and the difference even in just like wait times to see providers has changed
Right.
from 2015, 16 when all this started increasing to 2020, 2021. Now you might be waiting over a year and a half to get into a specialist versus like a month or two.
Yeah,
So
and I
you
think
got
that's a yeah,
burnt out professionals and
yes.
a
Right.
system that's very like does not really like leaving the time and the empathy for emotions. So it's definitely,
Yeah.
but it
Yep.
still means that because unfortunately, like even that needs to change, like that takes time if it happens. So it almost does put that responsibility on the patients to get the most out of their visit. Like,
Right, right. And I think part of that is to figure out how, going back to a little bit of what Stephen mentioned with regard to, we are showing up well enough at these appointments. We're putting on that, we're getting there, we're excited about the appointment, and yet we've got all of this, we collapse when we go home, and being able to put that onto paper. Like I've often thought that if people Zoomed with me at home and they realized that my house isn't a mess, or I'm not, I was a professional, that this, to give that fuller picture of me, then they would start to see that this is an anomaly. Like this woman, this was doesn't compute with where she was, 2 months ago or 5 years ago. And I think that's really important to be able to figure out how to do that. Um, from the standpoint of this is our timeline, and this is what in addition to this is what I felt like, but this is what I was doing in life. This is my capacity. And, like you were an accomplished nurse and go-getter and doing all these things. And now you can't do those things. And I'll just say that for me, so I'm into naming things, perhaps, I don't know, but I named my illness. So felt like it was from a virus. So my alter ego, when she shows up, her name is Vivi. And so I warn people, I mean, my friends and family, and I don't have a partner at the time right now, but um, I would say that that's Vivi, because I think even explaining it to our friends and family is just as difficult, at least for me, I'll say that for me, than it has been to the medical providers, because it's still invisible and still unpredictable. And so I've tried to give her a name, and they're like, "What's happening?" I'm like, "Vivi's in the room, just so you know." And so it lightens it a little bit. It's so that then there's less, for me, there's less discomfort, both for me and for the person in the room. But it's also tries to explain that she will pass. She is always with me, but how much she's here is dependent on my energy level. And so that is, but I do think that the one of the onus is on patients, which I understand, especially with when we have symptoms that show up unpredictably, is to figure out how to be able to give the physician that full story, whether it's videos at home or whatever it is, but then also to come into an appointment. And I know made the mistake of, I walked into one, I derailed this one, I know, because I came into a specialist and I gave him, 4 or 5 pages and here, okay. And that by this point, 15 things had been ruled out. And he's like, well, I don't know. I don't know what to do. And so I get that. And I gets back to one of the questions that I guess I have for either one of you with regard to, you know, setting expectations. I know that with my four-legged horse patients, I would talk with the clients about things that I couldn't fix or not fix, and be able to have that conversation. And I think having that, I never had it with any of my physicians of expectations of, let's talk about this. I can't figure out what's going on right now, but let's do some more work together, and maybe we can figure this out again to get some continuity of care. And is that something that is, again, it could be led by the patient, but do you think that there could be a way to stop you from being referred down the road to another appointment that, as Christy says, is getting farther and farther away from within reach? Is that something, Stephen, that you felt like you had any conversations, or even before you were on the patient side of things, that talking expectations was something that can happen?
Yeah, absolutely. And I'm also coming from a rehab focus, and
Mhm.
in rehab, we're always looking at functional changes and goals, and how do we live most optimally with how our body is functioning at the time, knowing the body can change, right? Um, so describing those hopes and triaging what's most important with recognition that it can and will change, right? Like I loved your description of, you show up and you're looking all put together, but your house is a mess, right? And knowing what your priorities are and having those in that kind of list or intentional approach is huge, with always that caveat knowing that it could change. It's tricky, but function forward has gotten me as a patient more gains. Um, and I wonder if part of that is it's a little more tangible when you can say, hey, fatigue is interfering in this way in this domain, and I would like to somehow find workarounds or ways of addressing it, rather than my cognitive fatigue throws me off, right? Something like wide and ambiguous, which is
Mhm.
true. However, again, trying to focus on something that's more measurable and definable within
Mhm.
function can be quite helpful. But a few of us have said this a couple times. Knowing what those things are
Yeah.
is hard baseline for anyone, especially if you don't have a background in nursing medicine.
Yep. Yep.
But
Yeah, I think that's a tricky wicket, and I think that uh, the push to certainly was within my own curriculum to fix. If the pressure is on to fix, then this function is secondary. So I want to fix this first, and then if I don't know the answer, then I'm going to move you on. But if there is that expectation, like I've lived like this for a long time, and I just want to try to feel better, and I really like, you might connect with a certain clinician. I want to stay here. I want to, I want to connect with you, and let's work on this together and figure out what my life can be like. And rather than, because we've got to be able to live between these appointments. And I think there's just a lot of discussion there. And so it is a tricky wicket with regard to, and I guess you mentioned fatigue a couple of times, and I would like to, I'm watching the clock, but I'm interested in how you, when I was developing illness, so the emphasis on and the terminology, ME was not part of the mix. I mean, even though it was. So chronic fatigue syndrome was sort of my label. And I personally really have hard time with that. And I don't know if either of you could comment, because when I tell people, I have chronic fatigue syndrome, they're like, yeah, I'm really tired too. And I'm like,
Right.
okay, all right, I get that. And so I hate the word fatigue, because I think the terminology that has gotten lost in all of this too is that ME is great, but a lot of people like ME, myalgic encephalomyelitis. That's a lot for a person. You and I can do it, but chronic fatigue is better, but it isn't better. And so I wonder what you guys use as your label with friends and family.
That's an excellent question. and I sometimes laugh, and again, it's kind of like that's me. I'm not trying to make light or be glib about
No.
things. Fatigue, I think about just the constructs we have to define these experiences, and which ones are better defined and which ones are more poorly defined, and then toss in, you know, the the character aspects. Fatigue is related to not working hard sometimes
Right.
in some social, cultural kind of underpinnings. So there's a character piece to it. There's, there isn't. I'm not indicating that. I'm just saying oftentimes you say
Yep.
fatigue, and that's what you get.
You're lazy, right? Yep.
You're
Yep.
lazy. So the precision, I think, for me is really is what I try to focus on when I'm relaying it. I try to break it up into the domain that is most pertinent. So if we are talking about cognitive fatigue, and it depends on who the audience is, or who I'm trying to convey this to, right? What does that mean, cognitive fatigue? What does that look like? Is that affecting attentional tone? Am I able to pay attention and attend to stimuli in a certain way? What type of attention could it be affecting? Is it getting in the way of making quick decisions and things like that? So just trying to make it precise and speak to domains where
Yep.
it is where it's impacting my life.
Yeah, it's and I appreciate that, and I think that what the other thing that I've struggled with is just being able to come up with something that's short and sweet and doesn't it's either I just say, I have chronic fatigue, and they have no idea what it is, or I start to embellish more, and they're like, that's too much. And so it's that middle ground of figuring out not to overshare, but I want people to understand. And I think that's something that, we will certainly need to dive into in our next conversation. And this is part one of many. And because I think it is that nuance of how to be able to explain. And but I think and I see Christy's comment with symptom trackers, I think is something that I think we all having that conversation, maybe that's one way to sort of say, I'd like to track my symptoms. Can I come back and we can talk about this? I'm a big advocate of using of virtual health, telehealth to be able to see me at home, because they might see me when Vivi is in the room. I would like them to see that. And they're like, whoa, who's this person? And then they would realize that she comes and goes. So, I think that there's a lot to this. And I knew in an hour we would only cover a small part of it, but I do really appreciate it. I don't know if there's any other questions from those in the audience. But I think that the